Welcome to Longevity Now FL. I'm Luigi Fontana, Professor of Medicine and the Scientific Director of the Charles Perkins Center RPA Clinic of the University of Sydney. Today, I would like to discuss with you the results of a new study suggesting that GLP-1 receptor agonist, the famous new anti-obesity drug, increases the risk of developing thyroid cancer. So, what are GLP-1 receptor agonists and why this is important? So, GLP-1 stands for glucagon-like peptide 1 receptor agonists that are basically incretin mimetics. These are a class of medication that have been proven to be effective in the treatment of type 2 diabetes and most recently for weight loss. Semaglutide in particular, sold under the brand names of Ozempic, Wegovy and Rybelsus, which comes as a weekly injection, has been going viral on social media because it causes significant weight loss. For example, TikTok Ozempic hashtag has been viewed more than 300 million times. Ozempic is now a Hollywood drug and it is in very, very high demand because of a worldwide shortage due to the fact that the pharma company Novo Nordisk couldn't supply enough Ozempic to meet an unexpected increase in demand due to off-label prescribing for weight loss. So, how does Ozempic cause weight loss? Well, semaglutide stimulates pancreatic cells that make insulin while suppressing glucagon, thus lowering blood glucose levels. But this drug that is mimicking the hormone GLP-1 also slows gastric emptying. These make you feel fuller for longer, and then it goes to the brain and suppresses hunger. And both of these actions help with weight loss. In clinical trials of Ozempic, people with type 2 diabetes not only improved their blood glucose and lost on average between 2.5 and 3.5 kilos, more than people randomized to placebo by week 30. In clinical trials of Wegovy, the other brand, study participants with obesity but without diabetes, so they had obesity but not diabetes, lost on average a striking 15.3 kilograms over 17 months compared to those who lost only 3 kilos with diet and exercise alone. Well, the problem, as it has been highlighted in this new paper that we are discussing today, is that data from a nested case control analysis of data from the French National Healthcare Insurance System database show that the use of these GLP-1 receptor drugs is associated with an increased risk of all types of thyroid cancer, including the very aggressive medullary thyroid cancer, in particular after 1 to 3 years of treatment. So let me repeat it. These drugs are associated with an increased risk of all types of thyroid cancer, including the very aggressive medullary thyroid cancer. In this study, the use of GLP-1 receptor agonists for 1 to 3 years was associated with a 58% increased risk of all thyroid cancer and a 78% increased risk of the medullary thyroid cancer. Of course, this is not data from a randomized clinical trial, so we have to wait, new data And for example, in an associated commentary published in Diabetes Care by Doctors Caroline Thompson and Till Sturmer, they conclude this, again, commentary by stating, it is possible that GLP-1 receptor agonists cause a moderate relative increased risk in thyroid cancer, but detection bias cannot be ruled out as an alternative explanation. They continue saying thyroid cancer is a rare outcome, and the potential increase in absolute risk is very small. Clinicians and patients need to always balance benefit and harm of treatments in light of their alternatives. And they conclude saying, in a population without specific risk factors for thyroid cancer, the benefits of GLP-1 receptor agonists will largely outweigh the harm. Well, I personally disagree with their conclusion, and time will tell. However, I personally believe in the physician oath that I took when I graduated in medicine of primum non nocere. That means first, do not harm. Probably, instead of convincing people that there is a shortcut to solve their obesity problem by taking a drug while continuing to consume unhealthy, super refined processed Western diets rich in ultra processed food, lots of animal products, salt and free sugars, over drinking alcohol, and leading a sedentary lifestyle, maybe more emphasis and effort should be directed in improving health education and promotion and clinical services, novel clinical services, to promote healthy aging since childhood, focusing on the importance of mechanism-based comprehensive lifestyle changes in preventing a range of extremely common cardiometabolic and oncological conditions that goes well beyond weight loss. I would like to remind everyone, for example, that in 1960 or in the 1970s in US, Europe, and most other countries around the world, obesity was a relatively rare condition, unlike now where at least 70% of adults are overweight or obese, and at least 25% of children are overweight or obese in many developed and developing countries. And yet, back then, when obesity was rare, there was coronary heart disease was a major public health problem. Back then, young, lean men and women were dropping dead because of an epidemic of myocardial infarction and coronary heart disease. A diet rich in animal fat, butter, lard, cream, cheese, eggs, bacon, and lots of red meat and salt, together with very high rates of smoking, were probably playing major roles in this epidemic. Then doctors and nutritionists started to recommend their patients to substitute food rich in animal fat with alternatives rich in carbohydrates, mostly refined, and vegetable fat, such as exchanging butter with the newly developed margarines prepared with trans fatty acids, causing an unprecedented pandemic of obesity and diabetes. Now we are back to high protein and most recently to ketogenic diets. The enemy, the bad guy, is not anymore fat, but is now carbohydrates. But remember that the words carbohydrates, fat, and proteins are generic and potentially misleading. It is instead essential, as I explain in my videos and books, and scientific articles to distinguish between healthy fats and unhealthy fats, healthy carbs and bad carbs, and healthy proteins and unhealthy proteins rich in methionine and brain chain amino acids. To summarize, the fight, the battle against obesity and diabetes, prediabetes, is only one single piece of a complex puzzle of unhealthy aging and of growing pandemic of metabolic chronic diseases, including cardiovascular disease, stroke, dementia, fatty liver disease, among many others. And reducing body weight with a medication most likely will not solve the underlying problems caused by the widespread consumption of unhealthy diets and unhealthy lifestyle. And as this paper suggests, it may even increase the risk of cancer, of thyroid cancer. The problem, as I've discussed in an article that we publish in PLOS Medicine, is that most of the research priorities and spending for health are focused on finding new molecular targets for the development of new drugs. Very little is invested in mechanism-based preventive science, medicine, and education. I believe that overly enthusiastic expectations regarding the benefits of pharmacological research for disease treatment have the potential to impact and distort not only medical research and practice, but also human, environmental health, and sustainable economic growth. In this particular regard, can you imagine millions of people using a plastic disposable syringe to inject a GLP-1 receptor agonist once a week for the rest of their life? What an environmental disaster is. Therefore, I believe that transitioning from a primarily disease-centered medical system to a balanced, preventative, and personalized treatment healthcare system, not a sick care system, but a real healthcare system, is key to reduce social disparities in health and achieve financially sustainable, universal health coverage for all. Integrating health literacy, both theoretical and practical knowledge, as soon as possible into education is key because it shapes health and well-being across people's life and for epigenetic reason before conception for generations to come. However, despite the wealth of mechanistic knowledge linking nutrition, healthy cooking, regular exercise, sleep, and cognitive training and health, these topics receive little or no attention in primary, secondary, and universities, including medical schools. School and university should not be a loose collocation of specialized academic silos, but transformative engines that provide not only the expertise needed to have successful careers, but also knowledge and practical skills on the mechanism and intervention linking diet and other lifestyles to human and planetary health. We need to invest more public and private resources to strengthen existing programs of disease prevention and create more complex and transnational scientific and economic analytic models based on multiple objectives and constraints. Additional resources are needed to develop science-based strategy, effective policy, and structural reforms that encourage integrated pro-health changes with the aim of achieving better healthcare, diets, mobility, and farming systems, not only in high-income nations, but also in low and middle-income countries. Critical global goals, which will require political engagement, should be to develop and deploy evidence-based intervention aimed at reducing behaviors associated with poor health prospects and environmental degradation. These could include, for example, lowering taxes and health insurance premiums for people who chronically engage in healthy lifestyle, making health foods more affordable relative to less healthy food, thus reducing health inequalities related to income disparities. Then taxing not only carbon but also animal and ultra-processed foods and beverages, ending direct and indirect subsidies for crops fed to animals and intensive animal farming, and restricting advertisement for unhealthy foods to children, implementing front of package nutrient warning labels, and enhancing food quality and exercise training in schools to help curb the growing epidemic of child obesity. These steps are important individually but take on particular significance when integrated by guiding principle for the design of an entirely new disease prevention center science, educational, and healthcare system that maximize both human and planetary health. And that's all for today. I would like to remind you that all opinions expressed in my videos are my own, and I hope this information can be useful to you. However, you should always keep in mind that the information contained in these and other videos of mine is of general nature only and should not be regarded as clinical evidence. Before undertaking any new diet or exercise plan or clinical pharmacological program, it is important to consult with your doctor or a specialist to gain professional advice relevant to your own specific clinical condition, health status, and situation. This is Longevity Now, Longevity Now FL. I'm Professor Luigi Fontana, the Scientific Director of the Charles Perkins Center Royal Prince Alfred Clinic and of the Longevity Program of the University of Sydney, and a clinical academic in the Department of Endocrinology of the Royal Prince Alfred Hospital in Sydney, Australia.